Greetings, everyone. My name is DJ Wells, and you've tuned into our latest edition of Coping with COVID, where each week we have important conversations about all the things that are going on as we continue to wrestle with this pandemic and some of the connected issues that we need to be aware of and conscious of as we continue to navigate this new normal. We talk about the new normal so often on these conversations. Today we've got another important conversation and a couple of esteemed guests to talk to us and with us about the way that addiction is impacted by this pandemic. And so I'm going to turn the conversation over to Dr. Mensah in just a second, but before I do so, I want to remind you that this is an interactive activity, and so those of you who are joining us, please do send your questions in at the bottom of your screen if you're watching on the computer, or if you're watching on your tablet or your phone, probably at the top of the screen. There should be a button that says Q&A, and you can click on that button. Type in your questions. We're going to let Dr. Mensah and our guests visit for about 45-50 minutes, and then after they've had their conversation and shared some important information with you, then we'll go ahead and share those questions that you're sending in to us during the broadcast. I also want to remind you that we do post the video replays of this video shortly after it's completed. So if there's great information that you're hearing while we're engaged in the broadcast, but you don't have time to write it down, don't worry about it. You'll be able to find the video on YouTube a little bit later. You can go back and rewatch it. You can share it with your friends and family as well. And so without any further ado, let's hand things off to Dr. Mensah and to our guests. Dr. Mensah, thank you so much for joining us, and please take it away.
Mr. Wells, would you like to introduce our two guests?
Oh, well, I can do that. I was going to leave that to you, but we have with us today Dr. Viviane Pecanha, who is the department chair of the International Psychology Department at the Chicago Professional School of Psychology. She is an international expert on addictions and on addictive, I'm drawing a blank on the syndrome, but she's
addictive disorders, addictive behaviors.
Thank you. I just having a brain cramp there for a second.
No worries.
So Dr. Pecanha is joining us, and also with us is Ms. Laurie Hadler, who is the clinical director of Footprints to Recovery. Those of you who are regular receivers of our newsletter and have followed Mensah Medical for years know that we've been partnering with Footprints to Recovery as a group that we're working with for folks that might need some additional support, some of our patients who might need additional support. So we're very happy to be working with Footprints and with Laurie, and thank you for joining us today as well. And now Dr. Mensah, let me hand it off to you.
Thank you, Mr. Wells. I am really pleased and, as always, honored to have our guests with us today. You know, it's so important for us to look at a different paradigm in medicine. And we've been talking about this for a very, very long time. And that paradigm involves more complete care. And you can't do that with just one practitioner. You can't do that with just one approach. And so, Laurie, I want to welcome you personally. After our previous meetings over at Footprints, I was so excited to be working with your organization and to be able to provide these opportunities for people who are having difficulties. And Dr. Pecanha, in terms of the international process and an international perspective, it's greatly supportive and just really sort of sharing with the world that no matter where we are, a lot of the same conditions still exist. Different culture, but many of the same problems. Now with COVID and everyone being sort of sheltered in and many people escaping, but nonetheless, those who are home having less and fewer activities to engage in, we see the whole addiction process increasing. We see widespread use of various drugs, including what is now in many places legalized marijuana. We see cocaine abuse, heroin, but everything has an opportunity to increase. And so I'm really glad that the two of you are able to come and join and talk to us about these things. And what I'm going to do is I'm going to be a little bit more quiet today. And I really want everyone to have a full understanding. And first of all, Laurie, can you tell our folks what it is that your organization does specifically?
We're an outpatient addictions treatment program. We actually have 3 levels of care: partial hospitalization, which is 6 hours of treatment 5 days a week, Monday through Friday. Intensive outpatient, which we actually have in all 4 levels of IOP. We can have as many as 5 days a week, 4 days a week, or 3 days a week. Most of the time that is 9 to noon. We also have an evening program, which is primarily used by people who are working during the day. So it's Monday, Tuesday, and Thursday from 6 to 9. We also have an outpatient level, which is kind of geared towards the individual needs that the patient has rather than actually structured time. We require that they attend at least an individual session once a week, but the patient and their therapist basically come up with a schedule based on what they need. So if they need particular group material, they can come to certain groups, certain days. But we have all 3 levels of care. And I do want to put out there that we have moved to Elgin, to where our housing is. And so we also do have housing for patients who are not living in a good environment and need to live in a sober, healthy living environment. And the next step that we're taking is within the next month or so, we're planning on opening a detox and residential at the same site. All of our Illinois services will now be at the same site in Elgin.
You know, that's great. I'm glad you brought that up, because so many, I'm not kidding, so many of our patients have talked about the underlying addictive issues that they've got. And they've asked, do you have facilities? Do you know of any place where we can go to kind of get a chance to sort of detox or to move through this process, whether they're daytime or full-time? So I'm glad you brought that up. So now people can see that, you know what, there is indeed help. There is indeed a place you can go. And we will have your information available for everyone at the end of this conversation. And it'll be on our website as well. So Laurie, thank you very much for that introduction. Dr. Pecanha, as we move to conversations in other parts of the world, share with us what it is you're seeing in your arena in Brazil, and where the role of addiction, well, the challenges of addiction are either doing better or doing worse at this particular point in time. It sounds like a silly question, but we would imagine things are actually getting worse. Would you say that's true in other parts of the world as well?
Yeah, it's not really a silly question, Dr. Mensah, because the pandemic, and before sharing my experience, I just want to say that I'm very humble and I'm very grateful that you invited us for this panel, because this topic is really important. It's important that we talk about how people are being affected due to COVID-19 pandemic in many levels. And several times, populations like those that are diagnosed with addictive disorders and chemical dependencies, they are most neglected due to discrimination, due to stigma, and majority of the time they are in the bottom list of the policies or the programs or interventions that are proposed by governments. And when I say that in a global level, because stigma and discrimination are actually identified by many studies around the world as obstacles to look for treatment in our diverse societies. So, as you can imagine, when we have a pandemic like this happening, where so many uncertainties, So many fears, they are raised. Those that are impacted by substance abuse, those that are in treatment in the recovery process, they are very vulnerable, and majority again of the times they are impacted heavily. Even situations related to triggering, craving and triggering the idea of using can come from, for instance, isolation, because a lot of the times the use is very, you see like several people that can be using at the same time, but that does not mean that they are interacting. That means that they are only sharing the same space. And isolation can definitely be a very important trigger. And as you all know, isolation right now and social distancing are the measures that are being recommended by the World Health Organization and US and several other countries around the world. Unfortunately, Brazil is not actually following that guidelines correctly. I mean, of course, I don't want to generalize that, because there are serious people in Brazil and serious governments and governors and mayors, but unfortunately, the current president of Brazil has been guiding the population to not use social distancing, to not be in isolation, to not be in quarantine. He actually is inviting and pushing, empowering all the people to live their lives as usual and do business as usual. And that unfortunately is reflecting in the number of cases, in the vertical number of individuals diagnosed and the number of deaths. Unfortunately, I believe Brazil is the second country right now with the most number of deaths, followed by US. So this has been not only a public health concern, but it's like a global health concern when it comes to individuals suffering and for many, many years in their lives and turning into addictive disorders. When I say addictive disorders, addictive behaviors, I mean like compulsive shopping, pathological gambling, excessive exercise to the point that becomes an addiction. So many other impulsive behaviors that sometimes even like the individuals that are suffering from chemical dependence, they move to another addictive behavior to in a way to deal with the anxiety, in a way to deal with the depression, in the way to deal with mood swings, in a way to deal with the uncertainties and the fears. Unfortunately, in Brazil, the number of individuals, the number actually increased in about, it's difficult to predict exactly, but major organizations that do study patterns of behaviors in Brazil, they are informing that about 30% or 20% of the number of the cases, they are seeing much more of these of individuals seeking for help. Of course, probably there are more that are not seeking for help right now, but this is usually what we are seeing now in Brazil.
And there's no surprise that the leadership of Brazil is very good friends with the leadership of the United States.
What a coincidence, huh?
What a coincidence. Laurie, Dr. Pecanha talked about trends, and have you at Footprints seen an increase in people actually coming for help, or do you think that people are really are engaging in their activities and just trying to numb the world out and actually aren't seeking any help at this point in time? Do you see an increase from, say, the last time we talked a few months ago?
Yeah, actually, in Illinois here, we get patients from all over the country, but certainly from ones that we're getting from Illinois, I would say like our admissions dropped off, I would say pretty significantly when here the shelter-in-place order went into effect. And clearly the other problem with that was that there was a lot less airline flights and things too. So even getting people from out of state dropped off significantly. As those restrictions started to get let up and eased up some, we started to see more admissions. We have, as I was telling DJ right beforehand, we have seen a significant increase recently. And I think it's, more and more things have returned a little bit, I don't say 100% back to normal, but a little more back to normal, which I think are people more are comfortable at this point coming into services. Now for like our housing, I think one of the considerations people have is if you were kind of stuck at home and pinned in, I think for a while people were uncomfortable with the idea of going into like a residential or housing setting because feeling again like they're stuck. So we've really been trying hard, and when people are calling into our admissions number, we let them know that we're doing everything we can and have been all along to be able to get outdoors, even if we can't go anywhere off grounds. Getting outdoors, it's something we've really pushed with the patients when they're here, is getting outdoors, getting the fresh air. We have a nice big courtyard area that they can go out to and still be on the grounds, but be able to be, out in the fresh air and such. Recently though, in the last probably several weeks, maybe 5-6 weeks, we really have seen the numbers go up a lot. And I think, again, as things have returned a little bit more to normal, I think people are more comfortable at this point seeking out services.
Laurie, is there a particular addictive element that you see more of than others at this point in time? Is it alcohol? Is it marijuana? Is it cocaine? What is sort of or is it a behavioral phenomenon, as in gambling or whatever? What do you see really as some of your more typical diagnoses that kind of come in now? Your most prominent ones, I should say.
I would say for the most part, it's still more of the substance use. Actually hearing reports from patients of things like when they were hearing that shelter in place was going to go into effect, literally going out and purchasing huge amounts of heroin or alcohol or whatever, fearing that if they're going to be stuck at home, what's going to happen. And I've literally had patients say they didn't know if they needed it, if they could get a hold of their dealer. So they were, a panic, basically, thinking of being stuck at home with nothing. I think there has been, actually, I've had several patients talk about, because during this, there was so much more like shopping online and such. A lot of them have talked about that's part of how they've dealt with the stress, and that is doing a lot of purchasing online. I can tell you from our patients, Amazon increased a lot of sales. So I think that's been one of the ways that they've kind of escaped it. But for the most part, I think it's really been, again, specifically their addiction that they're utilizing to try to cope during it. And what's sad is that I know around here, there were literally, once they started allowing like curbside service for certain types of restaurants and things, there's been restaurants where you can literally buy in a big container 96 ounces of margarita mix and take it home. If you're an alcoholic and you're worried about being stuck at home, and especially some have delivered, what better thing could you have than to be stuck if you're wanting to be an active addiction, you're stuck at home and you can literally have your addiction delivered right to your doorstep. So those are the things I would say primarily is what we've seen. We also have seen just a lot of, as a whole, there's been a lot more increases in overdoses, and that's been nationally. And again, I think it's just people are, to some degree panicking when they're not really sure how to deal with this. And we've had a few return patients And they've talked about their own relapses, and they've also talked about being like on Zoom meetings, which is for support groups, AA and NA groups like that. For a while there, all they could do was Zoom meetings rather than actual in-person meetings. And so we've had patients talk about when they were doing those meetings, when they were still in the recovery and trying to hang in there, they would attend those meetings, and so many people on those meetings would talk about how they relapsed. And I think there's nobody that really has dealt with this before. So I think so many of them already did not handle stress well, and they're put in a situation that none of them were really prepared for. And not knowing how to deal with it, their natural reaction is to just reach back out to their drug of choice and use that.
Laurie, how many of these folks who are coming to you are being sort of ushered in by their family? Or is this one of those things where people are sort of reaching in deep and saying, I just have to get help for myself. Let me come and explore, footprints?
I think it's kind of an even mix overall. I think the ones who have been like young adults who are still living with their parents, a lot of those, again, if they've been literally stuck at home with their parents and with other family members, I think there's been a lot of pressure for them to come back into treatment or come into treatment for the first time. And I think with some of them, it's been a case of their family may not have even known the full extent of their use previously because they could go and be out of the home and do some of it, come home, and maybe not have the family even have any idea of how much they were using. When you're stuck in the home, it's obviously going to be a lot more clear to the family. So I think there's been pretty even mix. I would say a lot of the ones that have come in on their own, it's been that their use, they have been able to figure out on their own that their use has really increased significantly during the time of this pandemic. We've had patients who are not necessarily our previous patients. Some of them are patients who on their own got into recovery previously, but a lot of relapses too have contributed to people coming into services, maybe a first time with us, but returning to services, and people who had gone like through 12-step meetings on their own to get into recovery and now are finding that that's not enough. I think it's been impressive how people have tried to adjust, like doing the Zoom meetings, but I've had a lot of people say that it's really not the same. It's you utilize it when you have to, but it's not the same as in person. It just doesn't feel the same. And so I think for some people, I think it's been kind of a stopgap measure. I need something, a Zoom meeting will work for me for the time being. For other people, I think it just did not allow them that connection that they would get in person. And so that also contributed. People who use their AA and NA meetings as a way to stay clean have really struggled and in some cases faltered because it hasn't been the same for them. And it just hasn't given them the same effect that it has in the past.
And isn't that one of the real difficulties here? Because we know that it's very effective to have that in-person communication, that in-person commitment and building those bonds that really help to get people through. And this is where I think both sides, Laurie, what you do, and Dr. Pecanha, what you do, both involve really in its best the in-person dynamic. So how do we move from here? How do we adjust to this other side, this other vehicle where, I mean, great, we didn't have two-dimensionality capacity 30 years ago, okay? So now we've got it, but it doesn't do enough. What can we do as measures to try to help bolster, to help support people in this next phase of recovery and treatment? Laurie, let's start with you, and then Dr. Pecanha, we'll ask you to chime in after that.
Well, I think the biggest thing that what we've been really working on our patients with here is the idea of whatever you have to do at this point to be able to get on track and stay on track. So even if, for example, Zoom meetings don't feel like the best thing for you, it's basically the idea of you got to do the best with what you have available. So we've worked with patients on how can you use Zoom meetings effectively. And being able to help them transition from in-person meetings to Zoom meetings. And one of the things we've worked with them a lot on too is the idea that there's so much talk of how some of this could be the new normal. And if that's the case, then how can you use what you have available now, such as Zoom meetings and things, or even like now there has been return to some live meetings. But if that's the case, and maybe some of the states go back to a bad case again of influxes and new cases, and so they get maybe another shelter in place, what can you have in place ahead of time so that you're not feeling completely overwhelmed and not knowing what to be able to utilize and how to be able to work the recovery. So with our patients, for example, just recently we've been able to go back to live meetings, AA and NA and such, and a lot of them are outdoors. Some places have not been able to open up and have meetings inside, so it's been outdoors. How can you use that to your advantage? And trying to teach them that if this is going to be the new norm, let's get used to this, and let's find out a way that you can use this so it doesn't have to feel abnormal, to really look at it as the new norm. Now, I would say too, with telehealth, we've used telehealth. We've had patients who have, a lot of them have even been at home where they would have preferred to come in live to services, but they maybe have shown symptoms or they know they've been exposed, so they're having to be at home in quarantine. And in my opinion, telehealth is not the best way. Again, I would prefer to provide services in person, but even with that, we've tried to make it as normal as possible. Like one of the things is, there's so many things you can do with technology. And so even when a person is on screen, and we may do like video clips that we're watching for some education portion, how to be able to do that so everybody, either in the group room present or those on screen from home or wherever, can still get that information. And again, just everything possible to try to make it as normal as possible. I will say too, I think we've increased one-to-one sessions, even again, if they even are telehealth, because so many people are feeling overwhelmed, and some are fine, some are coping with it fine, but making sure that they can get that individual attention. I think when you're really feeling overwhelmed, if you're in a group and nobody else is really feeling that at the time, you're more likely to not talk about that. So we've tried to increase the individual contact to make sure what people are really needing to feel comfortable for themselves.
Dr. Pecanha.
Yeah, as I am listening to Laurie, one of the things that initially come to mind is that when we think about treatment in our global societies, of course, we need to also keep in mind that despite the fact that we see same or similar behaviors of abuse in the diagnosis of chemical dependence and addictive disorders, we need to keep in mind that treatments are different. They vary in order to be effective. So as I always say, one formula will not fit all, especially considering the specificities of the cultures, the way the contextual structures they play in the treatments. For instance, politics, the economic structures, the social practices, how people relate to one another, and what it's most comfortable for them. Not only in Brazil, but in other collectivistic societies, people feel very comfortable in doing treatment supported by one another, doing like group therapy, and even that is facilitated by psychologists, or even like people within the community that are trained to do that, or even with the psychiatrists and other professionals. We in Brazil, we do have a multidisciplinary approach to treat substance abuse disorders and chemical dependencies, addictive disorders in general. Especially in Brazil, they are working with the individuals outside of the hospitals. They are seeing the individuals for instance, in the part that it's outdoor, but it's still closed and they have their privacy. Or in the community centers, because the hospitals, they have arms to the communities where the outreach professionals, they continue to do the work, but again, not inside the institution. also they are doing the same as Laurie said in Brazil and other parts of the world. They are having AA and ANA meetings in open areas, not only for the patients, but also for the families, because they are also suffering from what is going on, and they don't know what to do in order to assist their beloved ones. And that goes with what Dr. Karen Brown is asking. What we need to do, right? How we deal that. We increase the supportive system in order to help them. And that will be either online or that will be in this new format that we are doing, seeing the patients outside or in the outdoors. Of course, online will never substitute the face-to-face interactions, especially when we are talking about individuals that are suffering. So professionals, they really need to have that in mind in trying to be as more humanistic as possible, and be very transparent with patients, because it will not be the same. But even, talk about the difficultness of disclosing and talking about fears online. I think the more humanistic we are, the more transparent we are. We decrease the gap between the outreach, and that can certainly assist in the treatment and helping patients regaining the motivation to continue in treatment, helping the patients to see that there is still, possibilities even during these uncertainties of time to keep healthy and to seek healthier behaviors.
Thank you both for those commentaries. Whether we have COVID or no COVID, there's always a forgotten cohort in this whole process of addiction, and that is the family. Laurie, when you're working with the individuals who are challenged and supported, and Dr. Pecanha as well, what kind of programs do you have in place for the family members? They're traumatized, they're frustrated, they're anxious, they're depressed, they don't know what to do. Many of them, of course, are parents who've got parents that they're taking care of at home. Now their children, anywhere from 10 to say 30 something, may also are likely the patients who got the addictions. How are we supporting our parents, our caretakers, our family members through this process? So, for example, Laurie, does Footprints have a guidance pool of counselors that deal specifically with the parents, or is it done as a sort of a group dynamic relative to here's the patient, here are the parents, here are the family members, we have a session with them? How do you sort of work with family members while the individual in question is on the road to recovery?
Well, obviously, one of the problems is making sure that the patient is on board with having their family involved, and that's generally hit and miss. Oftentimes, depending on what's happened. I just had a session this afternoon, for example, with a young man who absolutely does not want his family involved. There's a lot of conflict between them. He sees this as his issue. He doesn't want them involved. I think he's very concerned that because there's been a lot of animosity, a lot of angry words spoken, that he really just doesn't want to deal with them. Our goal in a case like that, especially if their family is going to continue to be an active part of their life, we try to work at getting them to the point where they'll be willing to do family sessions with the family members and the patient present. One of the things we're doing, and some of this, again, specifically has to do with COVID, we used to have a family program on Wednesday evenings. Because of COVID, we had to stop that because we couldn't have people coming and going for that. So we do have on Thursday evenings, we have basically a web-based meeting, an online meeting, and it's a chance, it's really intended for the family, not for the patient or the addicted person, And it's every week. We have a clinical person who, it's one of our business development, but she's got a very good clinical background. She basically chairs the meeting, and it's an opportunity for family members, because a lot of places are not able to do family programming right now. It's a chance for them to be able to go on. They kind of do it as educational and also kind of partly as a support meeting. And so that's one of the things we've been doing ever since, I think it has been since towards the end of March, when most places went to the shelter-in-place orders. We do, for like the individual therapists here, their goal is always to try to find some family member that's going to be involved in the patient's life. And sometimes it's not a family, it may be a close friend, maybe extended family, but we try to find someone who is supportive of them to try to do some sessions. During COVID, we've done Zoom meetings for those. We've done FaceTime. We do, if they, for some reason, we have like grandparents who don't have a lot of that technology. We've done speaker meetings with them, speakerphone meetings. But we try with every patient, knowing that all the statistics show that the more support they have, the greater the likelihood of success. We try when they first come in, actually during their original assessment, we try to identify then a person in their life who we know is supportive, not just, I'm going to have my dealer as my support. Obviously, we're going to try to get them to choose someone who is healthily supportive of them, and then do whatever it takes. And in this time period, because of some people cannot be as mobile as they normally would, we're trying to use technology to be able to still have those sessions that we may have done in person before, now to be able to use all this other technology to still make them happen.
That's excellent. It doesn't matter what the condition, whether it's autism or whether it's schizophrenia or bipolar, families involved, addictions certainly, of course. And I'm so glad to hear that there are actual programs available that family members can access in order to help give them support while their loved one is going through this challenge. Dr. Pecanha, do you have therapy sessions as well for the family members of individuals that you encounter in your work?
Yes, very much so. Again, supportive systems, we are not only seeing in research, but we see in our daily practice that supportive systems, including members of the family or close friends that definitely would like to see their beloved ones in the treatment, they show us that the results are much better when the patients and the individuals, they do have the supportive systems. With the families, it's interesting the work that we do with the families, because several times when talking with them, they don't see themselves as someone that may be contributing to the addiction. They are already exhausted by what is going on with their son, their mother, their father. So they are already exhausted because before coming to the treatment, as you can imagine, there were like so many situations. They don't come right away to treatment, patients that do have substance abuse disorders. It's not typical. This is not the way it happens. It takes several years for them to make the decision to say, okay, I would like to have treatment. Or in Brazil, we have involuntary hospitalization, which means that the family, the psychiatrist can sign, and the person will be in involuntary treatment. Of course, has its own pros and cons, but this is something that we have in Brazil. Not only in Brazil, but there are other countries around the world that also use, that have this policy. But coming back to families, the same way we work with the patient to help understand triggers and what trigger behaviors and what what they can do, I mean, empowering themselves to get the ability to become more resilient, to deal with the stress of everyday life. We do the same with the families, because the families, they don't see themselves as part of contributing to help the patients, or even contributing for the patients to continue using substances, or to continue with the addictive behaviors. And it's, again, a long process with the families until they realize that sometimes they are the ones that are in one way or another assisting their beloved members actually stay in this unhealthy situation of looking to continue using drugs or continue using alcohol or whatever is the type of addiction that they have. So the same thing we do with the patients, we need to do with the families. And like Laurie was saying, even with the patients that are most do not actually want to include their family members or someone in the treatment, we talk with the patients. Of course, we don't impose, but we talk about benefits, the pros and cons of having the supportive system, and so they can understand and realize that this can be beneficial for them. But again, not having the family in the same mindset that they were having once they were before treatment. So, because if we continue with the families and the individuals with the same mindset, again, nothing will change. So the treatment needs to happen with the families and the individuals at the same time, if possible. If not, we do what is possible.
And you brought up, I think both of you actually brought up a very interesting point. You know, sometimes we forget that the reason certain individuals move into addiction is because of family dynamics. And so the family is not always necessarily part of the healing process directly, as opposed to secondarily. Mr. Wells, we've had some questions kind of pop up on the screen. Would you care to bring some of those up, please?
Absolutely, absolutely. And we've had a lot of conversation today regarding the use of technology and telehealth and that type of thing. And we've had a couple of questions regarding not only the effectiveness of it, but also any ethical concerns regarding telehealth. And if any of you wanted to address that, like I said, we've had conversation about effectiveness and the fact that you know, it's better than nothing, or you know, that obviously face-to-face and individual treatment is preferred. And yet, are there any concerns about providing health for folks dealing with addiction if you're not in a face-to-face setting?
I can actually comment a little bit on that. I know when we were looking at the shelter in place happening, people not being able to be so mobile initially, our clinical services were not located nearby our housing at that point. And normally our patients would come from our housing into our facility. So we were still in that situation. It's changed since then. And so we went to complete telehealth for group sessions and individuals and everything. And one of the things we did was we did have a concern about how secure are these things, always keeping foremost the confidentiality and for our patients. So we did our due diligence prior to shelter in place being ordered and did all sorts of research to find out what are the most secure settings. We would have staff and patients saying, well, can't we just do Zoom individuals and stuff? And we really wanted to find out what were the most secure. So we were able to do some checking and find out. We went to a certain specific website and link that was regarded as one of the most secure. Obviously, we all know that with technology, there's always things like hackers and that kind of thing. So that's why we found the one where the system is set up to be as secure as humanly possible. We're much more comfortable with that. And we have limited ourselves to that type of, like when we're doing anything on computers, limiting it to that particular site, so that we can rest assured that it is as secure as possible.
And Dr. Mensah, I know that Mensah Medical has just recently moved to offering telehealth appointments for some of our patients, and I'm aware also that we did a lot of similar due diligence, and that the platform that we've chosen is HIPAA compatible, that it lives up to all HIPAA standards and that type of thing as well.
Absolutely. Much to my chagrin, I've got to learn to use a computer. Molecular medicine I can do. This computer stuff is always a bit of a challenge, but nonetheless, we've got a whole team, that we've got working together to make sure that we've got the most secure process that is not, quite honestly, it's supposed to be very, very key in security and the utmost from a medical legal perspective. Okay, you got to meet those standards for medicine in order to do this thing, and it certainly is where we've assessed it to be, and we're looking very forward to putting that into place. And now that we've got an entire international network that we're looking at for help, Dr. Pecanha and all the individuals in the College of School of Psychology in Chicago, the Chicago School of Psychology, we now have to be actually extra careful, because we've got individuals who will be basically working with multiple providers in different capacities. And with this, we also have to ensure that the technology we use as one person goes from one provider to another provider to another provider is also very HIPAA compliant and secure. So at the same time, we've got greater opportunity working in a multidisciplinary approach that also makes us a little bit more vulnerable. It doesn't mean that we don't try, and it doesn't mean that we don't push forward. It simply means that we have to be extra cautious in doing this process the way we want to do it.
Dr. Mensah, oh, I'm sorry, Dr.
I was just going to complement, saying that more and more we will have patients living internationally seeking for treatment, and we need to be careful also to understand the rules and regulatory practices of the country where the individuals are located, in order to ensure we are not in any way violating any rule. So that actually poses another layer of complexity for us professionals, because we need to comply with the practices of other countries and the boards, let's say the medical board and the psychology board and the other, of course, disciplines that will be working together, especially when coming for treatments where several professionals will be supporting the treatment of the individual. One provider may be in Brazil, another provider may be in Italy, another one may be in the US. So we will need also on our end, we will need to ensure that we are communicating well with those professionals in order to develop like an effective treatment for the individual.
And that's so much what international psychology is about.
Yes, that's what it's about.
Regional experts who can understand the background of individuals and work with them at that level. Mr. Walls, I want to take a moment to thank PhD candidate Miriam Tafreshi for her instrumental work as one of our connecting pieces here in bringing all these wonderful experts in the world of international psychology. As she's from the Middle East, we can certainly envision a time where as Dr. Pecanha was basically saying, we've got to have multiple providers because you may live in the United States, so you may see Laurie at Footprints, okay? But then our families may be from Italy. Our families may be from Spain. Our families may be from Brazil, and they may literally want to talk to someone from their native country. And so this is where the technology and the psychology come together. And we have to double check ourselves to make sure that everything is secure from a technological perspective. I've got a question for Laurie. I know Mr. Wells has got another question coming up, but I want to ask Laurie this question. So you've got clients coming in from all over the country. Now, there are, of course, every state has its regulations around licensure for psychologists on a state-to-state basis, or therapists even. So how do you sort of accept a patient who's coming in or a client who's coming in from, say, Colorado into Chicago, or from New York or from Florida to come to Footprints for help? Are there those kind of technical challenges, from a legal legislative perspective, or is it more sort of fine-tuned if they're coming to your facility and you're not going out to their facility? Because now with telemedicine and telehealth, those lines are getting very well blurred.
Right. And actually, that's been one of the things we've had some people at our upper levels really working on. How does all of this, how does qualifications for staff and that all fit under telehealth? The biggest thing we found is that part seems to be more insured by the insurance company, if the person is coming in under insurance. If they're coming in and they're maybe private paying, which we get a lot of people who do that, then no matter where they are from, we have to make sure that we're following the state of Illinois' requirements and their regulations. When it comes to telehealth, there are some insurances that simply will not. Couple of things. Number one, some of them do not cover it. Most of them do, and I think some of them had to become a little bit more willing during COVID. But some of them have stated that we've actually had some patients who wanted to come. We've had to refer them to someplace back in their home state because the insurance will not cover them except in that state. Some of them have been very open to whatever state they are from. They will still cover it as long as all the other requirements for that insurance is met. Generally, as long as wherever the service is being provided, no matter where they're coming from, it's usually looked at, is the provider following the regulations for that state that they're providing the service in? And that's where it's gotten tricky with telehealth, because we're providing the service from Illinois, but they may be in Missouri or someplace. And then it really is by the insurance's expectations or their requirements. And I think, again, and my understanding is a lot of the insurances have had to make some changes to some of their requirements and stuff because of it. I would agree that if somebody is in, say, Tennessee, and they feel that a place like Footprints is the best place for them, certainly in the middle of a pandemic, it may not be the best thing for them to fly to Illinois. And then it really is up to the mercy of the insurance at that point if they agree with that and are willing to pay for the services. Sometimes they will say there's no reason why the person can't go to somewhere nearby. Our argument has been, what difference does it make if they can't be in person? And during the worst of the COVID, that was the case. Really, what difference does it make if it's a place 10 miles down the road in Tennessee versus a place in Northern Illinois? Really, at that point, it just should be who can provide the care that is needed, in my opinion. And we have people who have made that argument with some of the insurance companies that we believe we should be able to provide the services as much as anyone else. But otherwise, we just have to make sure with most insurances, their biggest focus is whatever state the services is being provided in, you have to be able to qualify or comply with all of their requirements, as well as whatever requirements the insurance has. So for example, a lot of insurances, you have to be licensed. That's the case with most insurances. I've actually incurred some where it's not even just, you can't just be like an LCPC or LCSW, you must be an LCSW, something like that. And then again, we just make sure that we are compliant with that. And if telehealth becomes an issue, our goal is to go to bat for whatever is in the patient's best interest and make sure that they're able to get whatever. When we have had insurances say they absolutely will not cover out of state for telehealth, then our next step is to work with that patient to find someplace nearby that has a quality program that we can get them involved in there.
Well, you bring up a great point, but here's the problem. And it's not a problem with you, it's a problem against the system that we're talking about. literally, if I had $1 for every time I heard a patient say, we have no one anywhere around us that can help us as a provider, let alone having a facility where someone can go to achieve help. People are traveling out of state so frequently because their home state does not have that level of services. So, you know, when you encounter some of those individuals, Laurie, I'm sure this is where you and your team go to bat to say, hey, listen, there's nothing, you know, you're an insurance company saying, I want to, you know, you got to find that provider in, you know, wherever have you. And that person's not a specialist. That person doesn't work in this field. That person doesn't have the background. Yet the insurance companies are still challenging. And these folks have to travel somewhere. So I see that.
Well, and one thing I will say that we have definitely encountered, and it's something that now, because a lot of insurances that are continuing to be more, some are uncooperative, but a lot of them are more open to continuing to do telehealth in certain settings. We've had people have come to here maybe and resided in our housing and done our partial hospitalization program with the goal that they want to go back home and go back to work as soon as possible. So we get them stabilized, get them at a good point in the partial hospitalization program. You know, obviously our goal would be to be able to provide more intensive services all the way through intensive outpatient and outpatient. When that's not an option because they really need to work and, you know, financially they're concerned about it, we've had the opportunity now to have them go back home. We get a lot of patients from rural areas where there are no services around. So if a patient wants to go back home, with the use now of telehealth more, they can go back home, and if it's an area where there is nothing in the area at all, we can continue to provide them services through telehealth. Several ways that is good. Number one, they get the intensity they would not get at home otherwise. And in some cases, they get treatment that they would not get at home if there's nothing nearby. And the other thing is that it's a nice continuity of care. They're here, they have a therapist that they're working with, an assigned therapist that's handling their case. They have a case manager here that they've been assigned to, that they have some rapport with, who knows their situation well in their case. They go back home. Really the only difference is that they're just not in person. Same people in their groups that were there when they left, same staff dealing with them, and it's a much better continuity of care rather than we're going to send you home and hope that you have some kind of support groups in the area because there's no treatment available. Telehealth has opened that up more, where we really weren't able to do that much before COVID, before people realized that there needs to be more accessibility. And there are plenty of rural areas in this country that any services, it's minimal, and in some cases, it's 50, 60, 100 miles before you can find any kind of services. And this makes this a lot more manageable.
Absolutely, absolutely. I'm so glad to hear that. Mr. Wells, I think you had another question for us.
I did, and actually it's kind of connected to this. You know, Laurie, you made such a great point about continuity of care. And oftentimes, when folks come to Mensah Medical looking for a very specific type of treatment, orthomolecular medicine, you know, we insist that we see that patient first in person. Of course, COVID has kind of changed that a little bit these days. But again, you know, sometimes we can then shift to telehealth after we've had that face-to-face visit because we've established that continuity of care. So a very good point here. The connection is that several of our patients are asking about the orthomolecular connection to addictions. Are there chemical imbalances that make patients more specifically vulnerable to addictive behaviors? You know, or is it more, you know, family settings or environmental settings that might trigger addictive behaviors, or is it a combination of the two? And then connecting it to our current theme for this program, one of our patients is also asking, if I've got that, whatever that imbalance is that makes me more prone to being an addictive personality, is that same imbalance more likely to make me prone to or vulnerable to infection by the COVID virus?
Okay. So let me kind of chime in here on this one. First of all, the answer to part one of that question is yes. Under methylation, That's the word you want to remember as far as addictions are concerned. Undermethylation has, as part of its underlying construct, highly addictive behavior and highly addictive capacities. So when we are talking about addictions, what is very clear is that the most susceptible individuals related to exactly what's happening relative to difficulties of cocaine, marijuana, et cetera, whatever those things would be, what we have is a situation where undermethylators are the most susceptible to having highly addictive capacities, but it does require a trigger. And in that trigger, we have to have some real consideration for environment, family, all those things. And so here's a very important concept. Well, my friend tried it and nothing happened to them, okay? You know what, my cousin introduced me to this, he's fine, he's functional. How wrong we are to assume that that works throughout the entire population. It doesn't. People with undermethylation are extremely susceptible to highly addictive capacities and behaviors, and so it makes them more susceptible to having a much more difficult time getting over addictions. So that's actually one of the pieces that we are working with organizations like Footprints and with international psychology to help them understand that indeed there's some things that can actually test for how difficult it may be to help an individual with these considerations, or maybe why they fell into them in the first place. Not everyone who engages in addictive behaviors does so and is stuck there. Overmethylators, for example, typically engage in addictive behaviors really as a way of soothing whatever kind of difficult emotional situation they're coping with, whether it's anxiety or depression or whatever have you. And then whenever that situation is over and done, for the most part, they can stop, okay? Same, that's true with cigarette smoking, alcohol, a variety of things that an overmethylator would engage in, similar to an undermethylator. The difference is that the chemistry makes it very difficult for an undermethylator to come out of that. And those are more likely the individuals who really have far more intensive therapeutic discussions with Footprints and with Dr. Pecanha and the folks in international psychology and with psychologists in general. And people don't understand because they don't know. That's what makes it all the more difficult to climb out of those kinds of addictive challenges when you are an undermethylated person. Okay. Now, undermethylation and COVID did not necessarily go together in terms of susceptibility. We have a much greater susceptibility with individuals who have pyrrole disorder or zinc deficiencies, and even vitamin C deficiencies, okay, or vitamin B6 deficiencies. These are the individuals that really are more susceptible if you're going to look at a correlation between COVID capacity and chemistry. Note I didn't say genetics, I said chemistry. They're not always the same thing. Genetics talks about potential. Chemistry talks about what's actually going on in the system. So these are the kinds of things that we would share with folks when it comes to, hey, you know, what does orthomolecular have to say about addictions? And we know that it is treatable. No matter which way you are, normal methylation over undermethylation, it's treatable. But understanding the intensity and whence this comes, that chemistry piece sheds light on what some of the greater difficulties are here.
And one of the things that also is important in this complexities of components that we need to consider when developing the treatment. The treatment is not only like the imbalance, as you said, Dr. Mensah. It's not only like the susceptibilities in terms of families. It's not only the vulnerabilities, the psychological vulnerabilities of the individuals, considering their specific cultural practices and what they were taught. But also we need to understand the extent of the damage of the substance in the brain. So for instance, if someone comes for treatment and has been using alcohol for, I mean, doesn't even need to be like a long period of time, but like depending also on the amount of alcohol or methamphetamine or cocaine or crack, whatever. We need to understand that all the substance, and not only substance, because we do have studies showing CAT scans of individuals that did have the diagnosis of compulsive shopping, pathological gambling, internet addiction. It's really important to see the damage that was done to the brain in order to identify the best route of treatment. Sometimes you will need to do neuropsychological rehabilitation prior, and then with combination of medication in order to bring the person to a place where verbal psychological treatment can be, we can start that. Otherwise, the psychological treatment will not do anything, will not benefit the individual. So we need to understand the damage. And of course, when I say damage, one of the things that are very interesting is like the neuroplasticity and the adaptability of the brain. After someone not using for 6 months, you see like this amazing it's interesting to see the images of a CAT scan when they start the treatment, their neuropsychological rehabilitation, and then again we do after 6 months and 1 year after they are sober. You see like sometimes the brain came back, or well, not came back, but really it's so resilient that was able to develop the neuronal connections where you can even say that the person was using the substance or engaged in that type of addictive behavior for so many years. Resilience and the adaptability and neuroplasticity of human beings is very interesting, but we need to understand what is the damage, if you will, with a lack of word, a better word, prior to starting a specific treatment. Otherwise, it will not be beneficial.
Just a couple more questions here that have come in that we want to try and touch on before we wrap things up here. One of our readers, one of our viewers, I should say, has asked about treatment or support groups and other treatment programs that are still meeting. And Laurie, you talked about this to some extent, especially the idea of meeting outdoors and that type of thing. But, you know, folks that perhaps aren't directly involved with footprints right now, are there resources out there for them where they can attend support groups or get involved with support groups in spite of or in light of the pandemic?
Yes, there are AA and NA have Zoom meetings. Most of the 12-step based support programs have Zoom meetings going on. And generally you can just go online and just basically put in the search engine AA Zoom meetings. And then again, now, certainly around here, I know where meetings are starting to open up, they are practicing all of the current rules. So that's why a lot of them are meeting outside, because they can do social distancing easier. But I do know a lot of that has opened up where there are meetings that either they're in big enough areas, like big enough rooms in that, where they can social distance inside. And a lot of what we're seeing is, you know, weather permitting, they're using like parking lots of maybe the meeting normally met in a church. They're now out in the parking lot where they can still provide the meeting and be compliant by doing the social distancing.
The other question that's here, and we've had lots of comments, folks that are agreeing with several of the things that are being said regarding neuroplasticity, regarding multidisciplinary treatment, that type of thing. So lots of folks chiming in and very much encouraged by the conversation. but the last question that really has come through is asking if there are places where both families and also clinicians can go to get some of the training that addresses some of the multidisciplinary and non-traditional approaches that have been discussed today. How can folks learn how to make use of some of these different strategies that have been discussed?
I'm sorry, were you asking that of me?
Of any of you. I know Dr. Mensah, we've talked about doing some workshops for psychologists so that they're more aware of orthomolecular medicine. Are there some other places where folks can go to find ways to integrate this multidisciplinary approach?
Specifically in terms of addictions and treatment that are offered, DJ, there are several centers and institutions around the world providing training for professionals that are already graduated, or also counselors that are working specifically with addictive disorders. Of course, it will depend where you are, in what part of the world you are, and what is specific type of training you would like to do, because there's so many possibilities in terms of the treatment of addictions. Several of them very effective. So it is a matter of where you are to understand how to better guide. And of course, I make myself available to respond questions, or to even provide links to places that are that do have credibility, that are places that you can trust in order to get the training, in order to be prepared to treat individuals and their families. So I make myself available to share that resources.
Very good.
And I want to be very clear with folks. When we talk about training, what we're talking about is education. We can't do what we're not aware of, okay? And no one is going to be trained overnight to do any of these disciplines at all, okay? We're talking years and years and years of work for what Laurie does, and years for what Dr. Pecanha does, et cetera, et cetera. What we're talking about is exposure to the educational process of awareness, so that we have direction to where we're going. And that's exactly what we're trying to build right now. We're trying to build these networks so that we can now share the information of what is out there for all of our folks and all of our team members. So I want to thank everyone. Laurie, I want to thank you so much for participating and taking time out of your busy day. You're doing fabulous work. I'm so excited to have you, so that people have a way that they can kind of approach and find a place to go for help. And then, of course, Dr. Pecanha, thank you so much for all of your international work and all of your great all the great challenges you've overcome to put together schools of psychology, and your fabulous students and everyone else who we've been exposed to. I want to thank both of you, and I'm looking forward to more work with you. Mr. Wells, we will have their information also available after this webinar is over, correct?
Yes. What we'll do is, well, I encourage, so why don't we have each of you give us some contact information now, and then we'll also post it with the video when we post the video. But Dr. Pecanha, you offered yourself as a resource, if you want to share an email address or something.
Yes, absolutely, DJ. I'm already including in the chat box my my email address, and please feel free to reach out to me using this email address. And Dr. Karen, I'm going to send you a study that shows exactly what I was talking about the differences in the brain after treatment, after neuropsychology rehabilitation. So stay tuned for that one. But this is my email address. Feel free to reach out to me anytime. It was a pleasure and a joy to be in the panel today.
And again, we will post that with the YouTube video, but it is V Pecanha, so VPECANHA at thechicagoschool.edu.
That's correct.
Again,
yeah.
we will post that in the comments section when we post the video. Laurie, do you want to share a phone number or an email address for Footprints?
I just put into the chat there my email address, lhadler@footprintstorecovery.com.
Outstanding. Well, thank you so much to all of our panelists. Of course, Dr. Mensah, thank you as well. And thanks to all of our viewers. Lots of great questions today that kept the conversation moving quite well. Again, I want to remind folks that we will be posting this video to the Mensah Medical YouTube channel a little bit later on this evening. We'll also post links to this video from the Mensah Medical Facebook page. So if you want to go back and revisit this, if you want to share this information with your friends and family, you can find the video in both of those locations. We also encourage you to continue to join us each week. Next week, we'll be speaking with folks from an organization called Journey's Dream to talk about suicide prevention during this pandemic, another important topic. We'll be talking about resiliency and empowerment and ways for us to personally overcome the challenges of the pandemic. So we've got lots of great stuff coming up for you in the weeks to come. Again, thank you for joining us. Thanks to all of our panelists, and we'll see you again soon.
Thank you.
Virtual hugs. Please stay safe.
Take care.
Take care.
Bye-bye.